Welcome, everyone. This is Amy Bilal from Maine Quality Accounts. I'm the Medical Director at Maine Quality Accounts, joined by our team at QC for Kids, Subat Stayan, Jackie Tyner, and Kayla Cole, and our national experts, Jen Powell, and James Wiley, and our friends at the AAP who are working on this project with us locally in Maine, Deb Hagler and Steve Meister. Today's webinar is Lessons Learned in the Previous AAP ADHD Collaborative, and how we can apply lessons to the CALM pilot. And Dr. Wiley is going to go over medication management. You are in listen-only mode. We can use the Q&A function to ask questions or make comments. Our video screen and size is adjustable. If you hit on the pictures, you can make it bigger or smaller. Jackie will be sending out an email with links to the slides and the recordings, and we will archive them on the website. This is under the umbrella webinar. Quality Counts under our Maine Child Health Improvement Partnership, and the mission is to optimize the health of Maine children by initiating and supporting measurement-based efforts to enhance child health care. Today's speakers have no conflicts of interest with commercial products in this presentation. I will note that funding for the CALM project is provided by the Pfizer Independent Grants for Learning and Change Group, which provides independent grant support to organizations for healthcare quality improvement and learning and change activities. The Pfizer Foundation is independent from the commercial entity Pfizer. However, funding for physician staff time is required under the Sunshine Act reporting, and QC receives funding for staff time and subcontractors under this grant, and subsequently we do report that time for the Sunshine Act. We do have CME available for participants who have signed into the webinar. If there's multiple people at one computer, please type their names and email into the chat box for our attendance records. We do not have separate nursing CEUs, but you can get a CME certificate. And we do have a CME evaluation survey that Jackie will send out. We ask you to complete that within a week, and she will send you out your certificates within the next month. So we have two main speakers today, Dr. Jay Wiley, who's the Chief Medical Officer at Focus MD. He is the ADHD Content Advisor for the AAP and their Chapter Quality Network ADHD project. He attended the medical school at the University of Alabama School of Medicine and completed his residency at the University of Alabama School of Medicine. He has done a lot of work with the AAP over the last several years around ADHD management, and he still is practicing as a primary care provider doing this. Jen Powell, some of you may have met at the end of our asthma quality improvement project several years ago. She is a quality improvement consultant for the AAP, and she is currently the quality improvement advisor on the ADHD project. And many of you have known the ADHD project at the AAP had a first cohort, and we are now in the second cohort with 5 other states. So today's agenda, we have a welcome and roll call. Because you're coming in as a and mute only, if you can chat into the chat box which practices are joining us, and we'll take a look at that. We have a quick practice report from Coast Pediatrics in our coaching corner, and then we'll turn it over to Jen to talk about lessons learned from the ADHD Chapter Quality Network, and then Dr. Wiley will do ADHD medication management. And we do realize that at the first learning session, there was a lot of conversation around medication management, and we asked Dr. Wiley to sort of build on that. So what's next? Once you started with a patient and maybe they're not responding or they have multiple comorbidities, what do you do next with the patient? And then we'll do questions and wrap up. So from the coaching corner, one of the things that we'd like to focus on is the model for improvement. What are we trying to accomplish? How will we know that a change is an improvement, and what change can we make to the results improvement? What we want for practices to talk about in our coaching corner is what have you tested since the learning session? What are you planning to test next, and other learnings? And I'm going to see if we have Deb Hagler, and she's going to talk about the work happening at Midcoast.
Hi there, can you hear me, Amy? I've got food stuffed in my mouth too.
We can hear you.
Okay, good. So Stephanie Phelps and I, after attending the group, the first group session, sort of tried to refine our aim statement. So we did it: improve management of ADHD by identifying and prescribing local behavioral supports and increase collaboration with the schools. So our huge big project, which we haven't really embarked on, although there's some useful things hopefully that will help us steer the way, will be to better identify behavioral resources in our community. We have a list from the CHAD website, has a great list with all the components of behavioral therapy in it. And so our plan is to talk to several of the counselors we use routinely in the area and see if they're comfortable doing some of these things. That's one of our things. But the other things are, from looking at our initial data, we almost use none of the Vanderbilts or get them back in a timely fashion to make med adjustments after that first couple of rounds of titration. So our goal is to improve the numbers of those that come in at the med checks. And a couple of things we're trying. One is we're working on reaching out to the schools, but the second thing is asking our reception staff when they make phone calls to remind people when they're coming in for their med checks to make sure that they've got those forms with them. And our office has on our website downloadable Vanderbilts, and I think I'm not sure if we got up there the little snap sheet that Carol Hubbard showed us at last time, but that will be on our website, so the schools can access that, or the parents can access that and then give it to the schools. So, and then the other thing we're hoping is that we can have our MAs, our medical assistants, at each well child check get an assigned consent to communicate with the school. So we're working on that. So the change we're trying to test right now is having the front desk remember to remind people to bring in their Vanderbilts with follow-up visits. So that's what's happening here.
Great. And you'll see from Sue, she had just a couple of comments for you. One is that getting your aim statement maybe to be a little bit more specific, to say by when, for whom, how much. So adding some numbers to that. So by May or by July, who's going to do the work, and if you had a sense of how much you are hoping to improve. She thought about that. And then the question about your reminder test is, what you're just talking about, testing it on a small scale, and then deciding how are you going to determine if that's going to, what does success look like before going to implementation. And thank you, Deb, very much for sharing. I know you had, this was what you were just talking about before.
Right.
I don't know if you have anything else to add to this slide.
Yeah, we are trying to count, and actually doing the data sheets is helpful for keeping track of the number of forms we're getting back. So that's a huge help. And the update therapist resource list for the staff, we have a plan in place. We have not implemented that, and getting more specific, as Sue said, will be of great utilization to make sure that gets done. A deadline's always helpful.
Great. And she says, great. You have measures that are tracking to test things beyond reporting as part of the collaborative. So that's great. And at the very end, when we do kind of updates on what's next, I'm just going to give you a couple of updates around the measures, because we've just tweaked a few things with feedback from the practices. So I'm going to turn it over to Jennifer Powell and Dr. Jay Wiley as they talk about some of the lessons learned from the Chapter Quality Network ADHD Collaborative. And we're really thrilled that they can join us today, because I think we want to make sure that we're not recreating the wheel on a lot of these projects, and that we can learn from what's happened nationally and really apply it to the work in Maine. So thank you very much, Jen and Jay, and take it away.
Great, thank you so much, and we're just excited to be part of this today. Let me do a sound check. Can everyone hear me? Can y'all hear me?
Great. I can't see you, so you're going to need to turn on your video.
Okay, let's see if I know how to do that. Start video.
Okay, you've got it. I do. Yes, perfect. You're on.
Okay. All right, so you can hear me, you can see me. Good. We're making progress here. All right, so let me just jump in by starting out by saying I have no relevant financial relationships regarding commercial products. So what I wanted to do today, and there were lots of lessons learned in our phase one, as we called it, of the Chapter Quality Network. And just as a reminder, I'm sure maybe this has been brought up, perhaps the learning session. We had five states that were involved in ADHD, which represented a chapter from each of these states, an AAP chapter. who then hosted a Breakthrough Series collaborative similar to the one that you all are part of in Maine. And so what we've done in preparation for phase 2 is we've put together a change package and a lot of resources. So what I'm going to be doing here with you in the next 9 minutes or so is really highlighting 3 of the lessons learned and showing you some of the tools that we developed that we will be more than glad to share with you all. So you can see here that the 3 lessons are sharing the workload across the care team. Second one, communicating with parents at diagnosis by what the parents called chunking it down. And then kind of a lead-in to Dr. Wiley, and certainly a lot of, it sounds like much of the content in your recent face-to-face learning session was on ADHD medication. For us, what we learned was that the physicians wanted continuous training, that they wanted reinforcement, they wanted more complexity around cases as they moved into taking on more of these patients. Next slide. So the first one, sharing the workload across the care team. I had been, so next slide. So so let me just start by showing you some data that I was sent. It was you all's pre-assessment data prior to the start of the collaborative. And this question asked, does your practice have documented protocols, standing orders, and job descriptions to distribute work across the care team? And the response was 100% that no. And of course, there are lots of pieces to this, but that's where we were when we started with these chapters in our phase 1 in the chapter quality network. And so part of what we did as a national team, the subject matter experts, was, well, what can we introduce that would really support this building of reliable systems around ADHD. Next slide. So these were the kinds of questions that we started asking our practices. Is work distributed appropriately across the roles? And are staff working at the top of their profession? Which we know leads to greater job satisfaction. And so we started exploring that, and we started thinking about what tool might be useful. Next slide. So part of my work as a consultant, I had started working with the McCall Institute, McCall Center for Healthcare Innovation. That's part of Group Health Cooperative. Actually, they're now Kaiser Permanente Northwest. But that's Ed Wagner's group who introduced the chronic care model. And they had been asked by Robert Wood Johnson to conduct I think it was more than a year, and Lisa Letourneau was part of this group. It was called LEAP, which was trying to leverage the exemplar practices in primary care across the country to learn what they had done to really foster practice transformation. And so they came up with what's called the Share the Care worksheet. And what we did was we actually modified this to ADHD. And again, we are more than glad to share this tool with you. But there were several sections to the worksheet. And so what you're seeing is a screenshot of this worksheet. So the sections that you see here is there was a whole slew of activities that fall under communication with patients and parents outside of the patient office visit. And then again, what we did was we thought about potential roles, and you can see those across the top. Next slide. And then there were sections on, go back a slide, preparing for the patient visit and proactive population management and patient visit tasks and patient education and coaching and care management. And then there was a section on administrative and quality improvement. And I have not cut and paste all of the details of each of the tasks that fell under there. But it struck me as Midcoast was reporting out in the first part of this program, how they were really demonstrating how they were thinking about how to distribute the work. They talked about the front desk person in terms of changing the script and doing a PDSA around that. Around how to remind the patients or parents to bring in the Vanderbilts. She also talked about the MAs, working on informed consent. So those are some ideas of that. You also talked about kind of how would you, who's responsible for updating the therapist resource list, and how often does that happen? Or you build it into the job description. So what we did was we asked our practice teams in one of their team meetings to come up with the current state. And what was, as some of them put it, shocking, was the fact that they, that to the extent the physician was doing most all of these activities. And so that really opened their eyes in terms of, wow, we really should think about this differently. So that was one key thing that I would describe as a key learning. So this next slide is just, again, what we were trying to reinforce was, you know, start by testing. That's exactly what Mid-Coast talked about. They're going to PDSA with the front desk around that, adding the script around the Vanderbilt scale. And then maybe you want to track and kind of come up with some kind of burden index as you're asking the MA to do one more thing, or as you're asking, you know, as you're thinking about redistributing these sections of work to one or more people in your practice. And then once you've got it nailed, you know, of course, considering protocols and job descriptions that reflect these standard operating procedures. And, you know, we know that that's really when you move to a reliable system as you move towards that standardization. Next slide. So here was our pilot phase results, just to begin and end with data. How much of your practice's care processes improved, and we had 100% that improved or significantly improved, and annotated that that sharing the care had a lot to do with making significant improvement. Okay, so let's move to lesson 2. So in our collaborative, we had a parent advisor that was identified by each of these chapters. And so they were working not at the practice team level, but at the chapter level. And we started bringing these parent advisors together and asking them, you know, if there were, what's the most high leverage things that you feel we should work on as a collaborative. And time and time again, what really surfaced, it surfaced in the parent interviews that we did with each of these advisors, and it surfaced in the learning session 1 when we had interviews with parents in the front of the room, was, I am so overwhelmed by this. And you're throwing out all this information when my kid was diagnosed, and I really had a hard time. And then half of them said, and what I came to find out when my child was diagnosed with ADHD is that I thought I had ADHD, and you know, and so you've got to think about how to communicate with me. Next slide. So with them, we came up with a parent conversation checklist. We came up with a checklist for the initial diagnosis, and we came up one for the first follow-up visit. And I'm not going to read through this, but again, they really helped us come up with this list. How much to talk about at the initial diagnosis, what kinds of things that you can give us, which of course we had the ADHD toolkit, but they really prescribed to us what they thought would be the right kind of dose for them, if you will, as initial diagnosis. Next slide. So again, here were the resources. This is part 2 of the initial diagnosis, understanding the ADHD booklet, pointing out additional resources, resource sheet for their state and local, recommending a preferred parent training program, and then consider telling the parents that you will discuss some of these materials with them at the next visit and encourage them to review in advance. Next slide. So again, this was our parent advisors checklist around the first follow-up. And there you can see there's a checklist. It's basically a script, a reminder. And so we developed this as a handout that the practices would actually have in the exam rooms. And so they kind of had it ready. It was really very helpful for the practice, for the physicians to kind of know that this was parent approved. Next slide. And so again, here, resources, reiterating the resources you provided at the initial diagnosis, and then references to the CDC parent communication resource. So that was, again, and this was a clinician tip sheet. So there was the checklist of what to talk to the parent about, and then a clinician tip sheet. So again, these were all developed by our parents, and believe me, it took us time because they all had to agree to what this content was, but it was really a worthwhile exercise. Next slide. Again, just more on a tip sheet. So again, these are available, Amy, we can make these available to you all in any, in part of the change package. So what I'd like to do now is to move to lesson 3, and this is, really how much it was important, and in fact, what rated the highest across the board in any of our learning sessions and our monthly webinars with the practices was around continuing to build their skills and competencies around medication management. Next slide. So you can see here we featured it in all 4 learning sessions, and we used case study format, and we used polling technology. So guess what? That's what Dr. Wiley will be doing with you now. So I'm going to go ahead, I think, with that and pass it on to him. So this was just some data telling you the level of confidence in managing and treating ADHD. All right, so with that, we'll go ahead and turn it over to Jay.
Well, thanks very much. It's great to be with you all, and I'll just get right to it. This is I'm not going to be. I don't have any financial relationships to disclose that are pertinent to the talk, and we hope that this will help pediatricians gain more expertise in medication management and medication optimization, troubleshooting some side effects. And we'll start with a case of a 9-year-old whose first grade teacher felt like he was hyperactive. And on those little behavior assessment sheets, he stayed on red and yellow as much as on green. And then he had to repeat second grade, although the second time around he did much better. Assessment from the teacher reveals that they feel that his reading and math achievement are on grade level, but now in 3rd grade he's beginning to struggle academically and is being teased by classmates as having to sit by himself. So next slide. Mom has says he has no confidence in himself. His self-esteem is plummeted. He wants to quit soccer, but he has his mood is otherwise normal. Mom is quoted as saying that homework at home doing schoolwork at home is a nightmare, and he's become anxious about failing again. He doesn't want to be unsuccessful, but otherwise he doesn't have anxiety symptoms. And then his Vanderbilt assessment revealed 8 of 9 inattentive and 5 of 9 hyperactive impulsive symptoms as occurring often on both the parent and teacher forms. And the first polling question is, does he meet the DSM-5 criteria for ADHD? So we'll get to that. And we can look at the results when we're ready. All right, and so 70% of you felt like he did, and about 30% felt like you needed more information or you weren't quite sure. So let's review those. This is a helpful thing to do. Let's review those criteria real quickly. So criterion A is that of the 18 symptoms, you have to have 12. Or you can have 6 of 9 inattentive symptoms, so it's or 6 of 9 hyperactive impulsive symptoms. So he met that criteria. And they should be occurring more than is developmentally appropriate for more than 6 months. Symptoms have to start before age 12. They don't have to have impairment or come in for an evaluation before 12, but somebody needs to remember that something was going on before middle school. The symptoms need to be occurring in more than one environment or context, and there has to be real impairment. In other words, there has to be either academic or social, and in adults, occupational impairment. And in this young man, he has failed a grade and is falling behind again in 3rd grade. Criterion E, I think, is an important one. in the first few minutes of an office visit, pretty much everything sounds like ADHD, and they can have enough symptoms on the Vanderbilt questionnaire, circle 2 or 3, to qualify for the number of symptoms. And then if they're under 12, of course, you check that box, and you can be very quickly down to these last criteria. But I think criterion E is one of the places that I used to get in trouble and can still get in trouble, not considering the differential diagnosis, because, you know, we're all trained that not all that coughs is asthma. Certainly an awful lot of it is. Not all that wheezes is asthma. A lot of it is. But we have to broaden that differential diagnosis to other causes for those symptoms. And so we need to think about differential diagnosis. So you've made a diagnosis, a DSM-5 diagnosis. The answer to that question was yes. There was enough data there to make the diagnosis. Then after just giving the diagnosis and explaining that, you discuss the benefits and risks of stimulant medication. And as often happens, the parent's first question is, why not start a non-stimulant? Or we've heard we should start a non-stimulant. So let's poll and say, or let's ask a question. Your response to that question is, and they don't have atomoxetine starter packs anymore because it's generic now. Then explain that stimulants are much more effective than non-stimulants for most patients, and ask if they still have concerns about stimulants and address those, and then tell them that Intuniv is FDA approved for monotherapy and prescribed 1 milligram. So let's look at our responses to that.
And Dr. Wiley, while people are polling, and we need 21 answers, and we only have half. One question came in for you. The last slide said before the age of 12, whereas a clinician said they thought that it was before the age of 6 they need to show symptoms, so they wanted to ask about the age.
Perfect. So you're right on track. It was actually 7 and below in the DSM-4 and the DSM-5. In addition to revising from Roman numerals, the previous DSM editions have been Roman numerals, and the DSM-5 is an English 5. But in addition to that, there were several changes from 4 to 5, and that included an increase in the age of onset. And the thought was that we were missing a lot of the inattentive smart girls in and amongst other patients that are missed before the age of 12 who weren't necessarily hyperactive and impulsive and behavior problems, which are the ones that tend to come to light at earlier ages. And so the inattentive patients were being overlooked because, especially if they were bright, they could hold it together till and have more symptoms in middle school. So that was the thinking there. Okay, so both of you, so we can, looks like everyone has the right answer, right? Because both of those answers can be true. So if we move to the next slide. The stimulants are much more effective, and the AAP guideline clearly says that the evidence is stronger for stimulants than non-stimulants, and they're also very safe. But parents still fear the stigma of stimulants, and some of us pediatricians are still, amphetamines or methylphenidate in kids' brains. It's a little counterintuitive. There's still a lot of misinformation about the safety of stimulants, which have a 30-year track record of being quite safe when used carefully. But yet the chronic care model reminds us that we have to be collaborative in our decision-making, and we really want to provide our expertise and query the parents as to whether they're on board now. So we'll move along. So this is a direct quote from the AAP guideline. The evidence is particularly strong for stimulant medications and sufficient but less strong for atomoxetine, extended-release guanfacine, Intuniv, and extended-release clonidine, Capvey, in that order. So that is quoted directly from the guideline. So I always get a couple of chuckles on this. So here are the good stimulants, including some of the newer ones at the bottom, and then the bad stimulants, because there is no pattern that's sustainable over time for one is better than the other. And despite what the newer drug reps may be telling us, we'll talk about how to find the right one for each individual patient. If you look at population data, all these medicines are safe and effective, but each individual patient will respond to them very differently, as we'll see. So they are reassured by your sage advice that the stimulants would be more effective and safer than previously thought, and they're ready to go. Which medicine do you choose? So what would you choose? And and you all are right on track, absolutely, positively. And I'm amazed. That's a great job, by the way. Those of you on the call who obviously are pretty savvy would be surprised to know how many people don't necessarily follow that pattern and choose a middle dose of or a low dose of a stimulant and then just go with that. But there are some caveats. I mean, you have to choose. Can the child swallow pills? Would liquid medicine be better? A sprinkle be better? Of course, I'm sure it's different in Maine, but in Alabama, very often the decision is made by what their patient's insurance and or Medicaid will pay. And by the way, congratulations on expanding Medicaid up there. I just have to get that in. And then this was put in as a joke. The pharma rep may have left a coupon to make a med trial more affordable than non-brand meds, and so that answer was actually put in as a joke. But one of our developmental pediatricians from Georgia said, "Wait a minute now, that could really be the reason you use the medicine, is that the pharmaceutical company could be cost sharing a little bit and make it more affordable for the patient." So we add that in there for consideration. All right, next question. So 3 weeks later, you prescribed Concerta, but that wasn't on the formulary. So you tried Metadate, which is a 6 to 8 hour acting methylphenidate product. And the result of that was this 9-year-old got a little more tearful in the afternoon. And you suggested trying 20 milligrams after reluctance. His mom gave the 2, and the irritability decreased. A little trouble going to sleep. This subsided with time, as side effects often do. We usually say give 2 weeks for side effects to go away, a day or 2 to see if the medicine's effective, and 1 to 2 weeks to see if the side effects go away. So increasing the dose can decrease the rebound irritability and rebound symptoms, which is surprising, but it does work. And also going up on the dose doesn't necessarily worsen side effects. They have to be monitored. So the teacher Vanderbilt improved, but there are persistent inattentive symptoms that are pretty significant, and still impairment with assignment completion, organization, and reading. Behavior has night and day improved, and they aren't seeing any side effects on the side effect checklist on the Vanderbilt, other than a little less appetite at lunch. Homework's still a challenge, and weight is pretty stable, as are his cardiovascular status. It seems to be the same old kid, no blunting or change in affect at the follow-up visit. And so now what? So you could continue the Metadate, change to Concerta or a different, let's just say if it's not on their formulary, a different formulation of methylphenidate, switch to Adderall, or add immediate release medicine. So what would be the next best thing for this young man in terms of your medication management? All right, let's see what everybody says. So on this one, there's a lot of division, and it is, but you did great. You got the point. The point is there's been a response to methylphenidate, and we definitely want to keep riding that horse, because we'll get to some numbers in a minute that'll explain that. But great job with staying with the methylphenidate, not switching classes to the amphetamine. So in continuing the Metadate 20, there are two problems with that. One is there's not going to be a longer duration of action, and there's still too many inattentive symptoms. So titration is key. We don't want to titrate to better. We want to titrate to remission without any significant side effects. So one of the things the MTA study showed, and we'll see that in a moment, is that we want to titrate to the most effective dose with the fewest side effects. So titration of that medication might lead to longer duration of action, and going up on the dose will also improve those persistent inattentive symptoms in the classroom. You could also consider changing the delivery system of the medication to a longer delivery system. Metadate CD is one of the medium duration of action medications. So you could increase the duration and increase the dose by changing the delivery system, but we would not go to amphetamine without titrating the methylphenidate. And it's probably not add a dose, even though adding a dose would help with the afternoon symptoms. Remember, this young man did not have his daytime symptoms. His school time inattention was not completely optimized. Okay, so we'll move along. And so I find that's really helpful. And one of the things we added to the change package was PK data. So the PK data, pharmacokinetic data, is in every package insert of every medicine. So since you all have so much time on your hands, I thought it would be helpful to let you all thumb through all the stuff that the drug reps bring in, or get online and find these. No, that's not what we did. I take that back. What we did was we had the folks at the Academy. This is, obviously this information is in the public domain. So we just had them put it into a PowerPoint so that you have it. But very often you can see with this, this is Metadate CD on the left, and you can see that at 10 milligrams, which is the dark black line, the lower dark black line, and then 20 milligrams, you can see that the concentration is definitely waning at by hour 7. Whereas with Concerta, you can, if you look over from left to right, you can see that effect may be waning more at hour 10 to 12. So a longer duration of action based on the PK data. One quick tip too, if this kid is having a headache every day at 11 o'clock in the morning and taking his medication at 7 o'clock in the morning, look when the peak concentration of Concerta is. It's about 5 hours post-dose. So asking when the headache is. It's also a reason that a lot of kids on Concerta don't eat much lunch, because the peak serum concentration is actually occurring. So I encourage you to use this PK data to compare when the patient's having side effects with the peak concentration, and also when the medicine is waning. And because, like, for example, Concerta has a pretty quick crash for some kids. All right, so let's, also it has a little slower uptick. Okay, so here's PK data on a newer medicine called Abtensio, and notice the dip in serum concentration at 4 hours. So I found that this medication sometimes is, if you can find it, this medication really sometimes helps get rid of the side effect of not eating lunch compared to Concerta. Just look at the PK data where Concerta is peaking between hour 4 and 5, and Abtensio, the one on the left, is dipping at 4 to 5. So having this PK data can be enormously helpful in terms of managing side effects. But nobody ever told us that, I don't think. So now we're to the 5 Ds of medication optimization. The first is the right drug. And it turns out that different kids respond to different molecules. Some kids will be amphetamine responders, some will be methylphenidate responders. Some kids will respond better to the D-isomer products, the Vyvanse and the Focalin, Vyvanse being the amphetamine D-isomer, Focalin being the methylphenidate D-isomer. So some people will respond to different molecules and isomers. Side effects and effectiveness are dose related. So that's why we're pushing this idea that titration is a good idea. You can't go by the kid's weight. You can't go by the kid's age. You have to go by the individual's metabolic response to these particular molecules. And unfortunately, if they're fast metabolizers of one, medication doesn't make them fast or slow metabolizers of the other. So we always recommend starting low go increasing the dose with titration until we find the fit that's just right. I always tell parents, if I give you a gallon of water, it's going to matter to you. We're down on 3, delivery system. If I give you a gallon of water, it's going to matter to you how I give it. So if I give it with a water fountain or a garden hose. And some of these medicines are just like giving a kid the medicine with a garden hose, and they really react negatively to it. They may do better on a different delivery system or time release formulation. And one final caveat about the PK data, it's pool data. When they print that in the product information, those lines are drawn through lots of individual data points and average. So some kids are metabolizing this medicine much more quickly and it's not lasting nearly as long. And those are the people who come in and say, but the Concerta's over by lunch. And we're like, that's not supposed to be true. But it is true for that patient. Or the ones that say he doesn't even eat dinner because the Concerta lasts too long. So remember that when you look at PK data, that's pooled data. And the next one. So I tell people this is what I do for a living all day long. I draw this box. I've even gotten pretty good at drawing it upside down and backwards so that I don't have to turn it around. But this box in which I circle the word you, and I tell the patients that there's nothing wrong with them, which is especially important with the middle school kids who don't want to be different, whether it's asthma, diabetes, the kids 13-year-olds that don't want to take their medicine because it makes them different. So I circle the you and I say, we're not trying to change you, right? We're not trying to calm you down. We're not trying to change you. We're trying to get rid of the problem with attention, because when we don't pay attention, we tend to get in trouble. And I'll even tell the little kids, when we don't pay and they'll say attention, we get in and they'll say trouble. They get it right away. So so what I do is I draw a line, and I don't have control of the presentation. But I draw a line out of the ADHD zone and into the U zone. And then, this is a standard therapeutic window. So the y-axis is effectiveness of the medication. So under the blue box, not effective. Over the blue box, side effects of whatever kind. And then on the x-axis, that is duration of action. So for busy primary care doctors, I have found that this one diagram gets to the questions I really need to know. Is the medicine working well enough without causing side effects? And is it lasting long enough? And so I encourage you to consider using this little simple diagram in your practice. Okay, next one. So now that goes to the duration of action, right? And isomers, dose, and delivery system all affect how the medication is likely to work. Just remember, each kid's metabolism is going to be a little different, so there needs to be a balancing act there. And finally, when I was a young pediatrician, we recommended medication holidays. We wanted to let the kid be the kid. We were worried about safety of the medication. And all of the new studies have suggested that daily medication is better. Taking the medication every day helps the side effects go away. So I quote that little rhyme very often: take your medicine every day and the side effects should go away. If they don't go away, it's because you're on the wrong dose of the wrong medicine. The other thing, in some kids, when they take their medicine daily, the side effects will get worse over time. That's especially true for very long-acting medicines. So if they do get worse, then to use a shorter duration of action medicine. But for most people, taking the medicine daily will eliminate the side effects or greatly reduce them over time, rather than recycling the side effects every August and every Monday. The other thing is that there is emerging evidence that daily medication improves executive function over time. And so we don't want half of the year, which is the non-school days in a year, to not have the ADHD under control. And we're trying to optimize for no side effects. All right, and so next. So Sarah's a 13-year-old treated for ADHD since she was 7, so about 6 years in, and she's been on Concerta 54 forever. But it's just not working. It's like she's not taking anything. She started her period about 12 months ago. We know that estrogen can affect concentration and ADHD symptoms, but she hadn't had any problems with her period. No new health problems or change in her psychosocial situation. Same school as last year, lots of friends. Grades have dropped, and the teachers are reporting some disruptive behavior for the first time in years. But she doesn't report any anxiety or depression symptoms. So then we have a polling question. So what should we do with Sarah, whose medicine has just, quote, stopped asking? So I've stopped working, I mean. Right. So I agree. The 22% of you that said compliance, that's number 1, 2, and 3 on my list. These kids in the middle school age group tend to start cheeking medicine. They don't want to feel different. They don't have even had to have side effects. And so that is number 1, 2, and 3 on my list. So, but also, we have to be aware that the Academy is on record as saying that we need to be screening for substance abuse in the teen years, and substance use can certainly derail ADHD treatment. So I would definitely screen for substance use disorder as well. The cheeking of medicine we talked about. There are medicines that were previously AB rated to be substituted for generic for Concerta as generics that are no longer AB rated, but there's still some pharmacists that are substituting those, and some insurance policies that may be mandating those. So we need to know, because they do tend to be less reliable in their delivery system and potentially less potent. It's important to note that the number 1 learning disability associated with ADHD is disorder of written expression. And so kids get to middle school, they've done okay learning to read, and they've done okay reading to learn. And the third part of education is now we say, well, kid, write down what you learned. And we all remember this from going through school. So as reading becomes more an important part of learning, that history and science, as disorder of written, as writing down what you know and short answer and essays becomes more a part of the academic equation, learning disabilities can show up in adolescence, especially in high IQ kids who could fake it before. So considering a psychological educational evaluation for these kids could be important. So with regard to Sarah, she denies substance abuse and noncompliance. The pill shape is the same. You remember to ask about sleep. Good for you, because remember that she could be staying up on her electronics. We need that 8 hours of sleep a night. And mom reported really that her reading and writing, even long sentences, have never been a problem. So we think we've ruled out these other things that we need to consider before a knee-jerk change in medicine. And that's the real point of this slide. Can we advance forward? We don't want to just automatically go up on the medicine without considering other factors. So here's some options for what you could do now that you feel like it really might be that things have changed and we need to consider or adjust the medicine. What would you do? Awesome. So 2/3 of you would go up to 72 milligrams. And this is the answer to the what am I thinking question is A, go to up to 72 milligrams. So titration before switching. One of the developmental pediatricians in Georgia that really should have a radio show talking about ADHD, because she's hilarious. Used to say, well, I'd rather fight than switch. There's some old cigarette commercial, not that we want to bring cigarettes into this, but there was this old cigarette commercial where it said, I'd rather fight than switch. So we'd rather titrate than switch. But so we did 2 things that were good. Most everybody said, let's avoid the knee-jerk increase about change in dose or change in medication without considering other factors. But titration to 72 milligrams would be probably the best next approach. All right, and then the next one, it helped some, but it didn't get her where she needed to go. She's still struggling, and she's begun to have some side effects that she didn't have on 54. She feels tired and now feels like it's affecting her personality a little bit and maybe even her sleep a bit. So the titration didn't help as much as we'd hoped, and she's still struggling. So what's the next step? And the options are a couple of different Vyvanse ideas, and then an Adderall. We could just tell her that's as high as we can go on the Concerta, or we could maybe add an alpha agonist. There we go. So at least about a fourth of you thought to add Intuniv or to go with a mid-dose of Vyvanse. And I think those are common responses. So if we can move forward to the, let's see. Okay, so this is what the AP has to say about stimulants and titration. Because stimulant medication effects are seen immediately, trials of different doses of stimulants can be accomplished in a relatively short time period. Stimulant medications can be effectively titrated 3 to 7 day basis. So, weekly titration may sound aggressive, but it's actually not as aggressive according to the guidelines as you would think, and certainly is okay. But the response best is probably B. It's time to try the other class of stimulants, and retitration is necessary. It is not a given that you can't crosswalk doses even between isomers necessarily, or delivery systems. The same number of milligrams might not crosswalk between different time-release formulations of the same molecule, or certainly not between amphetamine and methylphenidate. So you could be a high-dose methylphenidate patient, but that doesn't make you a high-dose amphetamine patient. So we have to retitrate, and start low and titrate up is the consensus from the experts that around the academy that we talk to. So retitration is necessary. Start with 20 of Vyvanse and then double it to 40. If you don't feel comfortable doing that, my same Georgia developmental pediatrician would say she would only go up by 10, and she would do it more slowly than I do it at 1 week. So, but not more than 2 or 3 weeks on the same dose, because you certainly should be able to assess by that time. So as early as a week and as late as 2 to 3 weeks, but no longer than that. So here's the study that informs that decision. 80% of ADHD patients who have a phenotype of the syndrome of ADHD, 80% of those patients respond to stimulant medication. And 60% of the 80% respond to both amphetamine and methylphenidate. But there is 40%, almost half of the responders respond to either amphetamine or methylphenidate. And this is why when I see patients who have tried Concerta, Abtensio, Metadate, Qualidigm, all of these methylphenidate, and none of them have helped, or they've tried Vyvanse and they've tried Adderall, and neither one helped. Remember this, that if you've tried one class and you've titrated your dose up to FDA approved, the middle to higher doses, that's the time when you want to switch classes from amphetamine to methylphenidate or back, or vice versa. Okay? 3 weeks later, she is much better on the Vyvanse 40. She tried 20 and went to 40, but she feels a little edgy and anxious, like I need to be doing something productive all the time. And she didn't feel that way on 20. Her friends say she's short-tempered and she's more argumentative on 40, but not 20. She's having a little more trouble falling asleep, and appetite is more suppressed than either on either dose of Concerta or the 40 milligrams of Vyvanse. So what would be a next step?
And Dr. Wiley, as they do the polling, you have a couple questions. Why would you go to the isomer before amphetamine?
So we didn't change isomers. We went up on the dose of Concerta and then switched to amphetamine. So we switched from methylphenidate Concerta 72 to Vyvanse, which is the D-amphetamine. Oh, if the question is why would you have done Vyvanse rather than Adderall XR or another amphetamine? The answer is it doesn't matter. You would try some other amphetamine. So that's a good point.
The second question was, do you see a role in the future for genetic testing to see which class they're more likely to respond to?
You know, I'm hopeful about this, and I think this is a great question. My experience with the current genomic testing for stimulants is that it's a coin toss, an expensive coin toss. I haven't found it to be especially effective for these medicines. But if you get into treating the comorbidities and you start using atypical antipsychotics and SSRIs, that testing is much more helpful and illustrative, I think. I think we'll get there with the stimulants, but I don't think we're there now. That's just a Jay Wiley view, not necessarily shared by everybody. And I think 70% of you did what I would do, which is to go down to 30 milligrams and split the difference. I think you could make an argument for trying Adderall because the L isomer is not as potent as the D isomer. So you're reducing the potency when you go from D to L. And that will also affect the delivery, the change in delivery system, and the isomer composition will also affect the duration of action. You all are doing great. So impressed. So just to review and I use water, maybe this is a corny analogy, but you know, you gotta have water. How much water is the dose? What delivery system? Definitely the isomer and the time release technology can significantly affect the patient's experience. The duration of action. You know, we don't want kids struggling with homework and at practices or events in the evening, and driving not on their medication. And daily medication is key to help the patient self-regulate behavior and build executive function and avoid side effects. This is just a graph that I draw this a lot. I like to draw, by the way. And so I draw this a lot. They're the 5 days of decrescendo side effects going down. Saturday and Sunday, I don't have any side effects because I didn't take my medicine. And then what happens Monday, I call it recycling the side effects every Monday. And again, just another point to make, if half the days are school days and half are not, 50% of the year, how can you ask an ADHD kid to build executive function in their environment if they're not paying attention? And then the other point that I make with parents is when they say that they can manage their kid, or they love their kid, or they feel guilty about medicating their kid, I tell them, you know, the medicine is not to control them. The medicine is to help them develop self-control. And by paying attention and decreasing their impulsivity and hyperactivity. So I tell them that no one needs a break from self-control. If we're using the medicine correctly and avoiding side effects, which we should be able to do with all the new delivery systems and doses, very tightly titrating the medication to the optimal benefit. So I do think it's worth pushing for 7-day medication, and especially in adolescents where it's been demonstrated that their risk of having accidents leading to ER admission, traumatic accidents leading to ER admission of all types, and also 3 times the risk of having an accident in the automobile while driving, and 5 times the risk of getting a moving violation when they're not on their medication.
Dr. Wiley, you have another question about what if a patient is losing weight on the medication? Do you still want them to do it daily?
Yeah, I do, but because, you know, a lot of the kids that lose weight, if you look at their BMI, they're losing weight from the 90th percentile down to the 65th percentile. Little kids, in my experience, don't lose weight as much, and it tends to be the kids that are more impulsive and overeaters, in my experience. But you're right, you do have to weigh benefit and risks, but I think that parents come in complaining he doesn't eat as much. And then as a pediatrician, I think we have to look and say, is that clinically relevant, or is that maybe clinically an improvement? And then navigate that conversation, taking the parent's concern very seriously. But compared to the morbidity of ADHD, increase in school failure, twice as likely to fail a grade, hampered academic performance, and hampered, for many kids, social performance, increased risk of trauma, in adulthood, doubles or triples the risk of substance use disorder, which, by the way, that risk has been demonstrated to go away. That increased 2 to 3 risk of substance use disorder goes away if you start medicine before 9 and continue through early adolescence. So I think that we need to be giving them the risk-benefit ratio, but we need to be certain that we understand it. So yes, I certainly do understand it. And the minute I see a pause in linear growth that's of any significance, then we really reevaluate that statement, but it doesn't usually occur.
And I do know we're getting to the top of the hour here. You had one more question from Carol Hubbard, who's one of our development pediatricians, really about the linear growth. What about growth in the newer MTA data about adult growth deficit on youth maintained on stimulants?
Yeah, I think that the MTA study is the study that has shown that. There are a couple of studies that show that it doesn't affect final adult height. And so I think you can't go by population studies. You have to really look at each individual kid's growth chart. And we do that at every visit, and as good general pediatricians, I'm sure you do too. I will say that I call it the check mark. So for the first 6 months, the kid may lose a little bit of weight, and you can see the percentiles drop, say from the 75th to maybe just below the 50th or to the 25th even percentile. And then what happens over the subsequent time, maintaining linear growth, of course, you want to be checking that. But the weight will begin to rebound. And I think this is especially true in kids that are treated more regularly, because the appetite suppression does tend to attenuate with age and with duration on medication. Parents always come in, the ones that decide to take a summer off so that they can gain weight, and they're always, at the first of the school year visit, they're always heavier. And when I see them back in October, November, because we follow kids every 3 months, that weight is almost always already gone. Because they just recycled their side effects. So I'll stop, and thank you so much for great questions. And
I want to thank both you, Dr. Wiley and Jen, for the great presentation and for sharing with us. We really appreciate it, and we're lucky to be part of this national project. I want to remind folks that we do have a webinar coming up on January 11th with Ross Green on collaborative proactive solutions for children with challenging behavior. And Carol Hubbard is coming back in February to talk about medication management and comorbidities. And Steve Meister will be talking about ADHD in children in foster care. Just a quick note on the data that's in QI TeamSpace. We have most of the team's data, but we're missing a few teams. If you still need help with QI TeamSpace, send Kayla a note and she'll walk through it with you. If you don't have 10 to 20 charts each month, report what you have. And you can print the run charts from QI TeamSpace and share them with your staff. There's an easy way to do that, and Kayla can show you. And always don't let perfect be the enemy of the good. You will notice in terms of the measurements, there was a few people who told us it was hard for some of the ADHD diagnosis. They were unsure, was it based on DSM-5 criteria because there was transfers in from other practices. Unknown is now an option to select. We've also added a psychologist who was the family referred to any following supports. And please note into QI TeamSpace, just put in any process changes or notes, and we can send those, and Sue and Kayla both see those. So I want to thank you all today for joining us, and thanks Deb Hagler and Midcoast for presenting. We will ask each practice to do a quick presentation in one of the upcoming webinars just to tell us how they're doing. And please let us know if you have any questions. And if you have any additional questions, please let us know. And I will say Carrie Woodcoff is just reminding us that the Maine Parent Federation can help parents navigate all different systems of care. And it's free with no qualifying insurance or waivers. So she's just reminding you, and I know many of you met her at the learning session, and we're happy to send you material from them. So thank you, Dr. Wiley. Thank you, Jen. And we look forward to working with you in the future. And thanks to all our teams today, and hope you have a good Veterans Day this weekend.